Recording in progress.
Just use the other one. Better. Good morning, everyone. We're going to give it another minute, but I just wanted to let everyone know that we will not have a grand rounds next week. It's a 1-week break between all of our faculty talks and the start of our fellows talk. We'll be back the week after with our interventional fellows, followed by our second-year Gen Cards fellows. And I'll also send out an email reminder so people don't show up next week. We'll get started in just a minute. All right, hi everybody, and hello to everyone online. Welcome, and today we are honored to have Dr. Sandhu speak with us. Dr. Sandhu, I know you all know well, but he is an assistant professor in the Division of Cardiology as well as the Stanford Prevention Research Center. His research includes using existing data to understand patient outcomes as well as current care patterns and the use of pragmatic trials to improve quality of care. He is the co-director of a center of the AHA's Health Technology and Innovation SFRN, as well as the co-PI of an AHA Rural Health Equity Research Network Center focusing on implementation of heart failure therapy. He is also funded by the NIH, the Gordon and Betty Moore Foundation, and multiple industry collaborations. On a personal note, he's been an incredible mentor to me and many of the fellows, and I think I learned more about methods and econ from him than I did my econ undergrad degree at Duke, so thank you for everything you've done for me and the fellows.
Thank you, Sneha, for the kind introduction. So here are my disclosures. I'm going to be talking a bit today about both using data to better understand quality of care, and then discussing some of our ongoing work testing different strategies for improving quality of care amongst patients with heart failure. So I actually changed my talk last week after this was published and kind of switched out the first half of my talk. For those who didn't see, it was a major announcement by JAMA that they were moving away from prior restrictions around the use of causal language around observational studies. Overall, I'd say that I'm quite excited about that. For everyone who saw David Cohen's presentation a few weeks ago, I think there's a lot of opportunity for robust observational study design to draw causal inference. But I'm also very concerned about kind of the quality of observational research that's published currently. This is just one example. During the pandemic, there were 169 studies published on the association between ACE inhibitors and angiotensin receptor blockers and COVID outcomes. This group did a qualitative assessment of all 169 of these studies to grade the likelihood of bias. And what you see, each row is a different study, and red indicates a high likelihood of bias, orange a moderate likelihood of bias, and green a low likelihood across several different domains, with the first column being the overall risk of bias. And they overall deemed that 3 of these 169 studies were deemed low risk of bias. And I think this is just an example, but I think this is fairly prevalent across the observational data space. Paul Heidenreich and I were actually funded to look at this question, and I think proud to say that we're one of the 3 studies that were deemed low risk of bias. But what I'll also say is, by the time we published, a year into the pandemic, many of these other studies have been published. It takes a lot longer, it takes a much more rigorous approach to the methods to do high quality work. And most of them were published at higher impact journals than where we published. And so I think this is just an example to kind of speak to the critical importance of us improving the quality of our work around observational studies. And personally, I think it's up to us as reviewers and editors to hold observational studies to higher standards if we expect to learn more from them and to allow them to make stronger claims. So I think this is talked a lot about in the causal inference comparative effectiveness space, but I think it also holds for descriptive epidemiology. And so I'm going to spend the next 10 minutes telling what I think is a fairly informative case of how study design matters so much in descriptive epidemiology. So this is an example of a study that was led by a phenomenal resident here at Stanford, Jimmy Zhang, looking at disparities in length of stay for heart failure hospitalizations. The AHA released a data challenge with the Get With The guidelines to evaluate disparities in length of stay across race and ethnicity. For anyone who doesn't know, Get With The guidelines heart failure is a registry of inpatient heart failure hospitalizations across approximately 600 hospitals around the US. It's a phenomenal resource for studies of inpatient quality of care. So we started with first describing the data. We excluded patients who left against medical advice, who were cared for in hospitals with substantial missing data, who died during the hospitalization. And then we looked at the length of stay. And as you can see, there's very little difference in length of stay between non-Hispanic, white, Asian, Hispanic, and non-Hispanic Black patients. So no disparities, analysis done. Obviously not, that's why we're talking about this example. So I think taking a step back, it's important to start with kind of a conceptual model of what could be the different components that drive differences in the outcome that you're looking at. And taken at a very high level, this could be differences in patient characteristics, how sick the patient is when they arrive at the hospital. This can be differences in how patients are treated within a given hospital. We call this within group differences. Or this could be average differences in how all patients are treated at a hospital, or between group differences. I think that's a really important distinction that I'm going to kind of focus on, but I'm going to dive back into a little bit more later. So which characteristics, which patient level characteristics should we adjust for in analyses in these? And I think the first thing I want to emphasize is this is a clinical decision, not a statistical one. So I think it again speaks to one thing that David Cohen got at, that to do good observational work, just like randomized work, you really need a mix of both methodologic and clinical insight and expertise. So we want to adjust for factors that are independent of the inpatient care decisions that we're trying to measure. So for studying hospital mortality or length of stay, we want to adjust for the baseline sickness of the patient, but not any of the treatment decisions that happen during the hospitalization that might mediate the outcomes that we're trying to measure. If we're evaluating the quality of post-discharge care, then we want to adjust for the inpatient treatments and even the treatments at discharge potentially, but wouldn't want to adjust for measures of post-discharge access, like how likely they are to receive outpatient visits after discharge. So for this analysis, we adjusted for the patient severity at the time of presentation, the age, the vital signs, the labs, and this is what we found in terms of length of stay differences. We found that they were larger after risk adjustment than what we found in the crude unadjusted rates. So this speaks to the importance of adjusting for characteristics that are outside of the differences in care that you're trying to capture. And in this case, we found that the differences increased, but it can also be the opposite. So this is a different get with the guidelines analysis that we have that's currently under press, where we looked at differences in medical therapy rates across sex, race, and payer status. And what you're seeing right here are the percentage differences in probability of being treated with these heart failure medical therapies for eligible patients between men and women. So unadjusted, women had about a 5% probability lower of being discharged on an MRA. And this is among women that have an ejection fraction of under 40%, no advanced kidney disease, normal potassium level. So all eligible for the therapy. But then after you adjust for age, ejection fraction, and comorbidities, that difference is no longer significant. So in our author meetings, we debated for a while which of these was the more important result to focus on. But I think the key is to understand both. Knowing that women are less likely to get treatment is critical, but understanding that how we treat patients that are eligible based on their age, their ejection fraction, their comorbidities is what drives that difference is critically important. So beyond adjustment for individual characteristics, it's important to understand and differentiate between differences that are within hospital or within clinic versus those that are between hospitals or between clinics. So again, within hospital is the difference in how a given patient group is treated at a given hospital compared with a different patient group at the same hospital. Between hospital are the differences in the average care between hospitals that then lead to differences across groups because certain groups disproportionately receive care at specific hospitals. And what I'm going to argue is that differentiating these two can be absolutely critical to interpreting our results. So now here's a toy theoretical example. Rural patients may have higher post-discharge mortality after a heart failure hospitalization. This can be because of individual patient risk, rural patients being sicker. It could be because of between hospital differences, rural patients receiving their care at lower quality hospitals, where the average mortality rate across all patients is higher. Or it could be because within hospital differences, rural patients maybe are less likely to receive post-discharge follow-up care, leading to higher mortality. And now just to really kind of hammer this home, I'm going to go through a graphical example. So assume there's a given kind of patient characteristic here on the x-axis, and you're studying that association with the outcome that's here on the y-axis. And then there's 3 different hospitals, which are these 3 different colors. And when you look, you can see that across all the hospitals, there's a pretty strong association between that characteristic and that outcome. So this is combining the within and between effect and showing that factor X is strongly associated with outcome Y. But let's instead actually adjust for the different hospitals that patients are seeing treatment at. And what you can see is that within any given hospital, the association between that characteristic and the outcome is actually quite weak. So now back to our length of stay example. When we actually adjusted for the treating hospital, we saw overall non-Hispanic white and black patients, overall non-Hispanic black and non-Hispanic white patients had very similar length of stay. If anything, length of stay was slightly smaller for the non-Hispanic black patients after you adjust for hospital. So the length of stay differences we see across the entire population are driven by which hospitals different patient populations are disproportionately treated and not differential treatment at a given hospital. And I think that the last thing I'll point out, which we'll come back to, is that after we adjust for the hospital, there was no association between patient-level neighborhood SES characteristic and length of stay. And this is not necessarily generalizable to any other sort of disparity or difference. This is, again, just an example for how these within hospital differences are important to tease out and characterize. So Jimmy does absolutely phenomenal work, and he even went one step further and did a really cool analysis, which is almost like a mediation analysis, by teasing out the differences across payers and disposition. And what he found is that the differences across race and ethnicity were predominantly present with discharges to hospice or to SNF, and amongst those patients that were uninsured or had Medicaid. So when I put this all together, Black, Hispanic, Native American patients had longer length of stay after adjusting for comorbidities and disease severity. But the differences were driven by the hospitals that they were disproportionately treated at, and not differential treatment within a hospital. In fact, the differences were mostly related to getting patients to SNF or to hospice. And so, when you have those results as opposed to just the fact that there are differences, it can really tease at what are the potential solutions and the avenues for solving these mechanisms. So maybe this is related to case management availability, or maybe to communication abilities of those case managers at those hospitals for dispo planning. Alternatively, and what I think is probably just as likely, this could be related to facility-hospital relationships. At Stanford, it might be easier for us to get an uninsured patient to a nursing facility because we have a really strong relationship of sending a lot of insured patients to that nursing facility. These differences across race and ethnicity are still very important, but the implications are very different based on kind of what's driving them. So the last thing I'll point out, and kind of tying back to what I started with, is this was a Get With the Guidelines data challenge, and it was quite cool. There were 3 papers on the exact same data set that were published in Circulation Heart Failure at the same time. And what's interesting is the other 2 papers also both looked at patient-level socioeconomic characteristics based on census data and the association with length of stay. And they both showed, and their main conclusion was patient SDOH characteristics drove differences in length of stay. Something that we showed that once you adjust for hospital, completely goes away. So, I'm just using this as an example that design decisions for observational research really matter, not only for comparative effectiveness causal analyses, but also for our descriptive studies of understanding the quality of care at our institutions. And when we're trying to understand differences across populations, which are some of the most important questions about quality of care that we have here in the United States, we really need to think about those different potential drivers of differences and not just stop at the very top line that there are or are not differences. So now I'm going to shift gears entirely, and I'm going to talk about some of our team's work on testing different care delivery strategies to improve quality of care for heart failure patients. And we give 3 examples for recently completed or ongoing work around that. The first one I'm going to start with is talking about patient-reported health status assessment in heart failure clinic. As we presented a couple of years ago in this format, there's many different ways to measure health-related quality of life. I'm going to be focusing on the Kansas City Cardiomyopathy Questionnaire, which is the most commonly used measure in heart failure. And I'm specifically focused on the short form 12-question version, which is designed for clinical care. So this questionnaire specifically asks about the frequency with which you have symptoms, and then how those symptoms translate to impact on physical and social function, and then how both the symptoms and the functional limitations impact your quality of life. It leads to both domain scores as well as an overall summary score. The importance of patient-reported health status is emphasized by this study, which compared the patient-reported KCQ to the physician classification of health status using the New York Heart Association, and found a substantial discordance between the 2. So here on the x-axis is the KCQ, 100 being optimal health status, 0 being incredibly poor health status. And what you see plotted is the frequency of a given KCQ score for different NYHA classification. So if you just start with taking a look at patients with a score of just about 50, which I can tell you is a fairly heavy burden of symptoms, you'll see it's a fairly even split between being called class 2, class 3, or class 4, with even a non-trivial proportion of patients that are called class 1. And not only is there this discordance, but KCQ in multiple studies has been shown to predict outcomes, not only the baseline KCQ, but also the change in KCQ. This is one of the first studies that showed that in 550 outpatients with heart failure across 4 different centers, and showed that even after you adjust for clinical characteristics, the KCQ is a strong predictor of outcomes. What's quite interesting is the NYHA also is a good predictor of outcomes. But once you add in all those other clinical characteristics we measure, the exam findings, the natriuretic peptides, the 6-minute walk, the NYHA is fairly attenuated in terms of its association with outcomes. But that's not necessarily as true with the KCQ. And then finally, and I think critically, we're incredibly fortunate in heart failure to have so many interventions that have been shown to improve patient-reported health status. And here's just a subset of such interventions from a recent review we wrote. So based on all that, the 2022 heart failure guidelines recommended that we start routinely collecting patient-reported health status, given its value for better understanding functional status, symptoms, and prognosis. Furthermore, Medicare and the AHA, ACC, have recommended quality measures that we routinely start collecting these measures across our clinic patients. But there was no data to understand the impact of routine PRO assessment among heart failure patients. So that's what we set out to understand in the PRO-HF trial. We wanted to know if routinely assessing the KCQ12 in clinic impacted patient-reported health status longitudinally or other care processes. We also assessed the impact on the accuracy of clinician health status assessment and on patient perception of their experience. So here's a schema of the trial. We enrolled patients before a visit to the Stanford Heart Failure Clinic via email, telephone, and text message. We then randomized them to routine KCQ12 assessment, where the clinician could see the KCQ12 before each visit, or to usual care, where we collected a baseline KCQ12 and another one at 1 year, but it was not visible to the treating clinician. We compared differences at a year, including differences in the KCQ12, and then we also surveyed patients and clinicians following the first post-randomization visit, and we interviewed our clinicians about the KCQ12. So for patients in the KCQ12 arm, clinicians could see the KCQ12 results in 3 different ways. One, we built it in Epic so they could put in a dot phrase for it to pre-populate their note, both the individual question responses as well as the scores. Second, they could review it in Epic tables and graphs. And finally, after that first clinic visit, we actually did a paper printout that they could review, although we phased that out over the course of the study. I was pretty overwhelmed when I found out that I had to enroll 1,200 patients on a K award budget. And it's a long story, but not entirely my choice. But fortunately, we were able to work with TDS to develop a fairly innovative enrollment design. And our heart failure clinicians, my colleagues, were incredibly flexible about the way that I contacted their patients. And I'm incredibly grateful to them for that. So we were able to enroll 500 patients without a single telephone call or discussion, just via email alone. And then the other 700 patients were a combination of email, call, and text. And in terms of representativeness and diversity, I think it definitely wasn't ideal. But I think when you look at the age for those that didn't consent across our clinic over that 1 year period versus those that did, I think it was better than a lot of other trials we do. And part of that might speak to the multimodality approach to collecting consent, and part of that might speak to our patient population. So here are the baseline characteristics. Median patient age was about 64. Just over half had preserved ejection fraction. And the baseline KCQ12 score was quite high, with a median score of 82. For those who don't, regularly see the KCQ12, most heart failure cohorts, Eldrin would know better, probably around 70 for most outpatient heart failure cohorts, would you say? So I'll start with telling you the impact on clinician assessment and patient experience. So following the first visit post-randomization, we asked clinicians 8 questions about the patient's health status and quality of life, including the NYHA class. For each question, we mapped that clinician response to a patient response, either on the KCQ12 or on a survey that we sent them. So for example, we compared the clinician's NYHA classification to the patient's KCQ12 overall summary score. For each outcome, we a priori defined what we would be considering concordant, intermediate agreement, and discordant. We also did the analyses as continuous outcomes, but I think the categorized ones are a bit easier to interpret. So the first row shows the concordance, the agreement, between the clinician assessment of health status via the NYHA and the patient's assessment via the KCQ. And what we found is that for patients in the KCQ arm, where the clinicians had the results of the KCQ-12, there was about 50% higher odds of agreement between the patient and the clinician assessment compared with usual care. And this was true for 7 of the 8 questions we asked, including around quality of life, symptom frequency, and expected health status stability over the next year. After that first clinic visit, we also surveyed patients about their interaction with their clinician. We asked them 8 questions about their degree of agreement with positive statements regarding the clinician's perception of their health status, their communication with their clinician, the alignment of treatment goals, and then other general questions about the relationship with their treating clinician. For the health status questions, we found patients had higher odds of strong agreement with the statement, "My clinician understood symptoms related to my heart, and my clinician and I agreed on how I was doing overall," with modest absolute differences of about 6%. Interestingly, we did not find any significant difference in the communication questions. There was also no significant difference in the alignment of treatment goals or in the clinician-patient relationships. So now I'm going to shift and move on to the final results at 1 year that we just presented at ACC about a month ago. Overall, we had high completion rates of the KCQ-12. Over 98% of patients in the PRO arm completed at least 1 KCQ-12 that was available in the EHR for their treating clinician. And the completion rate across all clinic visits for that arm was 87%. About 87% of patients alive at the end of the trial completed their final KCQ-12. Here are the primary results. We did not find a significant difference in the KCQ-12 at 1 year between the 2 arms. The mean difference in the overall summary score was 0.2, with 95% confidence bounds from -1.7 to 2.0, and our results were consistent across each of the individual domain scores. We also looked at guideline-directed medical therapy rates, visit frequency, hospitalizations, found no significant difference in any of those outcomes. Our results were consistent across each of our pre-specified subgroups, including the median age, sex, and median ejection fraction. We did do 2 post-hoc analyses where we found significant differences in the results. First, we stratified patients based on conventional NYHA thresholds for the KCQ, and we found a larger benefit among patients with a baseline KCQ-12 of 60 to 80 that traditionally corresponds with NYHA class 2, compared with those with milder symptoms or more severe symptoms. And then second, at the very strong encouragement of John Spertus, we surveyed clinicians at the end of the study, and we asked them about their use of the KCQ-12 over the study. Again, incredibly grateful to my heart failure colleagues for filling out all of the many surveys that I've sent you over the last couple of years. We stratified clinicians based on their median response as to whether they were heavy versus limited PRO users. This was based on whether they described that they looked at the PRO, whether they discussed it with their patients, whether they incorporated into their decision-making. And we found there was suggestion of larger benefit amongst those that were heavy PRO users as opposed to limited PRO users. I think there's some critical limitations in this very pragmatic trial. We're at an academic heart failure center with highly specialized heart failure clinicians that you're going to see about your heart failure. That's not how heart failure practice is around the country, where most patients with heart failure aren't even seen by their general cardiologist on an every 6-month basis. Being open label may have led to spillover effects, changes in how we assess usual care. I think even more importantly than that, it was hard, I think, to get into a routine of looking at the data when, probably at most 1 out of every 4 of your patients, probably even less than that, actually had the KCQ during the trial period. The cohort was overall less symptomatic at baseline. It's definitely harder to improve quality of life when it's quite good to start. And then finally, something I'm really interested in is we only assessed quality of life during clinic visits. It can be quite a while between clinic visits. Our average in this study was 2.5 clinic visits over the course of a year. There may be more value in kind of assessing quality of life in between clinic visits as a part of ambulatory monitoring. And that's something that I'm going to tell you more about shortly. So overall, PRO assessment didn't improve quality of life, didn't change testing, treatment, or follow-up rates. In post-hoc analyses, we found larger effect in those with intermediate health status and with clinicians with greater self-reported PRO use. We also found PRO assessment did improve the accuracy of clinician assessment. During our qualitative interviews, which I didn't describe to you today, most of my colleagues are pretty supportive and want to continue the practice. I think the reason why is interesting. I think it varies a lot from one clinician to another. I think we have a shared care model. I see a patient, one of the advanced practice providers see them, I might see them again for 6 months. It can help with kind of objective assessment over time. For others, it gets maybe a bit more of an objective assessment from the patient than what they hear in the side of the clinic room. For others, it's a matter of efficiency. It's nice before you even walk in the room to know if this is going to be a quick, easy visit, the patient's feeling good, and you can talk about their dog, or if they're actually feeling really bad, you really need to dive into their symptoms. But I think regardless, I think this is a great example of how we need to continue to develop and test strategies for how to better incorporate this into routine care. There is and is coming a really large push for routine PRO assessment. And we don't want this to be another thing in healthcare that is done, is checked off on a box, and doesn't necessarily help us deliver care better, like so many of our other national quality improvement interventions. And I think we owe it to patients, because patients are, generally happy to fill this out, but only if the clinicians find it valuable and are using the data. I'm next going to shift into some of our other work, testing different strategies to improve the optimal use of medical therapy for heart failure patients. And these are both kind of ongoing projects that we have. We're lucky in heart failure to have many therapies that substantially reduce morbidity for patients with heart failure with reduced ejection fraction. It's been estimated, I think many of you have probably seen this table on Greg Fonaro's talks, that the combination of 4 therapy classes, commonly referred to as guideline-directed medical therapy or GDMT for heart failure, reduce the relative risk of mortality by over 70%. Despite that, we persistently have suboptimal use of such therapy. This is slightly older data from a cohort of 140,000 veterans with recent diagnosis of heart failure with reduced ejection fraction over a 7-year period. These are treatment rates after incorporating contraindications. So we excluded anybody whose last blood pressure was under 100. For MRAs, we excluded anybody with a potassium over 5, et cetera. And what you can see is that MRAs, for example, which reduce the risk of death by 30%, remain used in less than 30% of eligible veterans. RNA use was increasing, but still was used in less than 30% of veterans 4 years after its release. This data is very consistent with other registries like CHAMP-HF that have been released. But I think it's remarkable because veterans have access to low-cost medications, low-cost clinic visits, and lab testing, and the treatment rates are the exact same. So I think one of the great implementation opportunities in cardiology is really promoting the effective use of medical therapy for heart failure. And this is a big problem that many different people, fortunately, have been working on. There's been many different strategies tested for this. I'm going to give you a few recent key examples that really inform some of my thinking. The CONNECT-HF trial was ran by Adam DeVore at Duke, was an incredibly important trial of improving medical therapy after heart failure hospitalization. Intervention was a hospital-level quality improvement strategy based on the idea that if they helped sites understand where their gaps were and gave the sites detailed feedback about what they needed to improve on, sites would improve on that. The study included 161 hospitals, including Stanford, and over 5,000 patients. It's remarkable, not only was there not a significant difference in clinical outcomes, but if you look here in this graph on the right, these are the quality metrics that they were reporting. There wasn't any significant difference in any of the treatment rates that they were reporting back. So this is fairly compelling data that just telling health systems, here are your gaps and here's how to do better, isn't enough. So maybe instead we need to give the recommendation about what to do at the point of care for a specific patient when the patient's in front of you. Multiple trials have tested clinical decision support at the time of a clinical encounter to promote medical therapy. Some of Paul's work around, alerts at the time of echo, really kind of the forefather for a lot of these trials. This is the PROMPT-HF trial, which was run by Tarek Ahmed at Yale, and I think it's a great example of this work. So they randomized 100 clinicians to either usual care or to receive best practice alerts at the time of visits for heart failure with reduced ejection fraction patients that included alerts about eligible medication up titrations. These were smart alerts. They incorporated the patient's current medications, their allergies, their contraindications. They delivered the alert for just over 600 patients. And as you can see, it led to a 10% increase in GDMTF titration. So the trial was a success. But even in the intervention arm, 60% of patients had no up titration. And the majority of patients at the end of the study were still on only 2 of the 4 medication classes, despite 3, having generic options. So alerts might be effective, but they still leave a really large gap. And the third and final study I'm going to mention, which I think was really paradigm shifting, was the EPIC-HF trial run by Larry Allen out of Colorado. So they took 290 patients with heart failure with an upcoming clinic visit, and they had them watch a 3-minute animated video about how heart failure meds are good, and then they gave them a sheet of paper. The sheet of paper had their current list of medications, the target doses for medications, and it just had a simple message: work with your doctor to make one positive change. An incredibly simple intervention that led to a 19% absolute increase in medical therapy intensification. I think this really nicely demonstrates the concept that patients can be their own best advocates for optimizing therapy if they understand the importance and they know where the goalposts are. So I think this is something that's really been the central thesis behind our AHA-funded .HF grant, which is a collaborative project I'm leading across Stanford, Michigan, Hopkins, Cincinnati Children's, and Boston University as part of our Health Technology and Innovation Research Network. So what our goal is to take what they did in EPIC-HF, digitize it, add patient-reported health status to make it even more powerful. So we want to know if we help patients understand their med goals, track their health status and how they feel over time, give them educational materials available on demand, can we turn them into advocates and partners for increasing their medical therapy? So we built an app. We built the Engage-HF app through a human-centered design approach. We had a bunch of patient panels, clinician panels, met with content experts from around the country over the course of about a year. And the app basically had 4 features. It had the medication checklist, as I mentioned. Zara Azizi, our star fellow last year, built 15 educational videos that we incorporated into the app about heart failure medications, the importance of heart failure monitoring. We incorporated vitals monitoring because it's critical for both recognizing disease worsening as well as tolerance of medical up titration. And then we incorporated routine KCQ12 monitoring, both so patients can see how they feel as the meds are up titrated and also to help detect decompensation. The data is shared back with the patient, both as they collect it and intervally, and then it's also shared with the treating clinician at kind of actionable time points, either when the patient has worsening health status, when there's an opportunity for med optimization, or there's an upcoming clinic visit. So we just finished about a month ago a 17-patient pilot here at Stanford, and we learned a lot. Despite the human-centered design process, we made a lot of mistakes, especially around the trade-offs around comprehensiveness and usability. Patients, especially our patients, our heart failure patients, needed it to be much simpler to be usable. Patients wanted us to remove some of these daily questions we were asking them because they didn't quite understand how it was being used. Their clinicians never brought up the daily questions. And then they really, really needed us to simplify the Bluetooth vitals connection. The other part that I thought was really interesting is despite us having our central tenet behind this, again, being to motivate and activate the patients, their primary goal for collecting this data was because they think their clinician wants it. And if this makes it easier for my clinician to gather this data, they're all for it. So we realized we need to give more positive feedback to the patient of when we're sharing this data to the clinician to continue to motivate them to do the collection. The clinicians we talked to, and we haven't talked to everybody, so for those in the crowd who didn't like it, raise your hand at the end. But the people we talked to generally liked the data that was coming in because it was both actionable and it's mostly the stuff that their nurse is already collecting. Just right now, our nurses are calling them every week to ask them what their blood pressures are, or they're sending in those long tables on Epic, which we kind of eyeball, like what does the blood pressure really look like? We also saw that about 50% of our notifications led to some sort of clinician action, whether that was a communication with the patient or a med change. And 45% of our alerts about med optimization led to med intensification. So we're now working to adapt the app ahead of a multi-center trial that we're hoping to launch this fall. We also, one part that I think was really cool about this project is we adapted the app into a Brazilian version called Opt-HF, with a partner, Luisa Brant in Belo Horizonte, Brazil. She's testing it in a very socially vulnerable population in the public health system. We finished a few months ago completing a pilot study that had incredibly high rates of daily app use. Almost every single person used the app every single day, much higher than in the US. So we're now, we adapted their app as well, and we're now in the middle of enrolling in their trial across 4 different hospitals in their public health system, hoping to have results early next year. In addition to the 2 trials that I mentioned, we're also working to adapt this app for rural Idaho, where the primary care population wants primary care and cardiology population want a way to kind of better monitor their heart failure patients. So excited about that as part of our AHA Rural Health Equity Research Network. What I really love about this project is it's been an incredible example of reciprocal innovation. Very different health systems between rural Idaho, Stanford, even Stanford, Michigan, Hopkins, and Brazil. And each one has kind of really helped us understand the population in very different ways and what the potential solutions are. I'll also mention, again, a huge thank you to my heart failure colleagues who've been very gracious with recruiting their patients, both in clinic and outside. The Educate HF trial, which we just are finishing enrollment this week. So we built these educational videos, and then my nurse, Julia, said, do we actually know that patients will learn anything from these, or that they'll like them more than just like reading this on a sheet of paper? I said, that's a good question. She said, well, why don't you do a trial of it, Alex? And I said, if you help me. And so we did. So we did a 128 patient trial that was a crossover study comparing educational videos with text versions, both assessing knowledge attainment of the 2 different versions as well as patient preference. So big shout out to Julia for that, as well as Zara for making the videos, and hope to present that at AHA later this year. Finally, I'm going to talk about an approach to improving heart failure care that I'm really excited about, both because we've been working on this a lot at the VA, and now there's a big effort to incorporate this to our care at Stanford, which is incorporating pharmacists into GDMT optimization. Jimmy Zhang also led this wonderful meta-analysis of non-physician heart failure medication optimization trials and showed that both pharmacists and nurse-led medication optimization protocols lead to significant increases in both initiation and up-titration of heart failure medical therapies. At the VA, we're lucky to have academic detailing dashboards and a really broad investment in pharmacists, both in primary care and cardiology. So pharmacists can use these dashboards to identify patients on suboptimal therapy and work with them on medication optimization. Over the last few years, many of us at the Palo Alto VA have really been working on expanding that program, as you can see on this bar here. So we've kind of done educational sessions and meetings with individual pharmacists to substantially increase the number of heart failure medication adjustments made at both Palo Alto and Livermore compared with our colleagues up north. And we look at national data. When pharmacists are involved in heart failure care for a patient, those patients are far more likely to have treatment with heart failure medical therapy, as well as up titration of those therapies. And the VA has seen this data, and they've strongly encouraged expansion of primary care pharmacist heart failure management. But despite that, we still see very low rates of actual management across the country. So the question we've been asking is, how can we ramp up the use of pharmacists for heart failure management broadly across the VA? So Paul Heidenreich and I were fortunate to be funded by the AHA to test a strategy to do just that. The audit, we're specifically testing if audit and feedback combined with education can increase heart failure management by primary care pharmacists. We're doing this over 2 stages. The first stage is here in our local region, Sierra Nevada, where we are testing this audit and feedback intervention across 110 primary care pharmacists. We're going to hopefully have the results of that over the summer. And then after we find those results, we'll subsequently be hoping to scale this across 3 other VA regions around the country. So the pharmacists are randomized to 3 different arms: usual care, those that receive education in addition to feedback about their own heart failure medication adjustment, which I'll share with you in a second. And then finally, a 3rd arm that receives patient-specific feedback about patients in their panel that may benefit from heart failure medication adjustment. So our educations included the development of best practice documents, titration protocols, and monthly educational webinars where we discuss heart failure medication adjustment and some of the challenging cases that pharmacists may come across. And then we're actually building a database of all the questions that the pharmacists have asked over the last couple of years and going forward, so that it can be a living kind of resource for pharmacists around heart failure medication problems. We've been incredibly lucky to have Alex Steverson really leading this effort with us over the last year. She's led many of these educational sessions, has been absolutely instrumental in kind of putting together this whole package. So thank you, Alex. In the patient-specific, well, I'll get to the patient-specific feedback. So these are what the audit and feedback reports actually look like. So we tell the pharmacists how many medication actions that they've done over the last 3-month period and how that compares to their site and their peers. And then we also share with them information about where heart failure medication rates are in their local region, so that they kind of know what is the target that they're trying to aim for. Not necessarily an individual number, but that they see a goal over time and kind of feel like they're improving as a group. The patient-specific feedback is actually a list of individual patients in their panel that have gaps in their guideline-directed medical therapy. We're, again, very lucky at the VA that we're able to take this data directly from dashboards that the VA already makes, with the hope that this will eventually encourage them to start looking at the dashboard themselves and shift more to a population health management perspective. So, overall, this has been a bit of a whirlwind of some of our ongoing work on how we can work with patients to improve cardiovascular quality of care in a learning health system. I have, 4 big picture takeaways. First, there's incredible power and potential to activate patients around the quality of their care. I think we all know that clinic visits are short, and we have to focus on what the patient wants to focus on. But if patients understand the kind of same goals that we have for helping them feel better and live longer, I think it can really potentiate our ability to improve quality. Second, I think digital health is an incredible opportunity to extend our interventions beyond the walls of our clinic, where patients spend very little of their time. But we really need to pilot digital health interventions around usability before we ever get to efficacy testing. I think we've seen most digital health studies fail. And a large driver of that is kind of the limited usability. And I think that, my early experience has been, we really need to spend a lot more time on the implementation usability side before we actually get to the efficacy. And then finally, we need to do robust evaluations of what we implement to ensure it's having the effects we intend, or else so that we know how to redesign it, like for PROs. A lot of people I'd like to say thank you to across the many teams and groups that have been working on this. Again, echo a huge thank you to my colleagues in the Heart Failure Clinic who've enabled us to do all of these studies with our patients. And then to the many collaborators I've been lucky to have, and my family, obviously. Thank you.